Hello, I'm Vibeke Strand. I'm a rheumatologist and clinical professor adjunct in the Division of Immunology and Rheumatology at Stanford University. And I'm presenting today a EULAR poster called Systematic Radiographic Progression in Individual Joints Before and After Methotrexate plus Adalimumab treatment in patients with early rheumatoid arthritis. Now, it's a bit of a complicated poster, but I think it's of interest because what we're really looking at is a very early disease population. Patients were required to be less than or equal to 2 years disease duration, and in fact, the mean disease duration was 0.8 months. In these patients with such early disease, we were looking to see what joints were involved on radiographs, in other words, already structurally damaged. And then we were looking to see which ones were most likely to progress. And as you well know, there was a statistically significant difference between adalimumab plus methotrexate versus methotrexate alone in inhibiting radiographic progression. And this would have been expected because this was a methotrexate naive population. Nonetheless, what we found was very interesting in terms of the joints that were involved at baseline and those that were most likely to progress. And the take home, which we'll be back to later, is that these are the joints that are surveyed in the SHARP score when it's done formally for clinical trials. But also, these are the joints, at least in the upper extremity hands, meaning fingers and wrists, that are used for MRI in rheumatoid arthritis, and thus indicates that MRI is also an accurate way to look at progression or lack thereof of structural damage. So if I start first, what I want to say is that we looked at all the patients in this protocol and looked at all those who had both baseline and follow-up x-rays. The study was 2 years in duration, and we have data both at baseline cross-sectionally and then to look at it at 1 and 2 years to see the effects of the treatment. And although there were differences in the effects of treatment between methotrexate and the combination adalimumab methotrexate, what's interesting is that the joints that were most likely to progress were similar, although they may have shown less progression in the methotrexate arm. It's a very complicated series of figures and so on because we're looking at individual joints cross-sectionally, but I think I can walk you through it. The other point which was of interest to us is that the right and left hands looked almost identical in everybody, regardless of whether they were dominant right or left-handed. So we've combined the hands and the feet when we look at the different joints. So we're only showing you individual joints as a composite bilateral joints. So one of the first figures, figure 3, is the percentage of patients at baseline that have either joint erosions or joint space narrowing. And the first point is that it's interesting that more joints have erosions, but some joints have very prominent joint space narrowing. And this is in patients who have anywhere between 0 and 2 years of disease, which indicates that probably joint space narrowing is not just cartilage loss, it's probably ligamentous laxity, it's probably inflammation, it's probably changing the architecture of the joint. So this poster has actually shown us, when we get done with all of the analysis, that there must be two different processes that underlie what causes erosions and joint space narrowing. And they're clearly also influenced by the stresses that are put on the joints. So as we look at this, we'll see that often the feet, particularly the MTPs, are going to show a lot of damage and a lot of progression, which is probably not surprising since we walk on our feet. So we look at figure 3, and the top one is in green. It's a percentage of patients at baseline with joint erosions. These are the number of patients or percentage of patients who have any erosions in any of their joints. And as you look across the figure, what you can see is that essentially there's a lot of damage already in these patients in the MCP joints and the PIP joints of the hands, but also that the MTP joints of the feet show damage, and particularly both the wrist. The wrist around the navicular, it shows the most percentage of subjects, 60%, who already have erosions, but we see it also in the wrist and lunar and the radial ulnar joints. If we now look at baseline joint space narrowing, rather than a maximum of about 60% of patients having erosions, we have in joint space narrowing the maximum is about 40 to 50%, and much fewer joints actually already have joint space narrowing, with the exception of the hands and the MTP first of the foot and the wrist. So what we see is that all the PIP joints are involved, and up to 40% of patients have involvement of their PIP joints, and it's about 30 to 40% for some of the MCP joints. So this probably means that that's the kind of stress in the way that they use their hands and their fingers, and that would make sense. The next thing we did was to look cross-sectionally at the odds ratio for involvement of the joints according to erosions or joint space narrowing. And basically one sees that certain joints are more likely to progress. If we look at joint space narrowing, we see that the wrist is where we see a lot higher odds ratio for progression. The PIP joints, which I showed you already had more involvement at baseline, actually don't show much progression. In other words, the joint space narrowing is present and it persists, but it doesn't appear to worsen. However, there's a fair amount of joint space narrowing worsening in the foot joints, and when we look back over to the erosions, we see the same thing. There's a lot of progression of erosions in the feet, and interestingly, there's a fair amount of progression of erosions in the wrist. So that's, again, a cross-sectional look. Then, if we look at the probability of individual joint erosions and joint space narrowing based on RA disease duration at baseline, we see an interesting pattern. So this is figure 5, and basically what it is it's the patients who've been enrolled at baseline with anywhere between 0 and 40 months of disease, which would fit the 0 to 2 years of disease. And what we see typically in most of these joint pictures is that it goes up over time. So in other words, the more they've had disease, the more progression they will get. We see that type of pattern for erosions in the MCP joints, with the exception of the MCP1. We see it for all of the PIP joints for erosions. We see it for the wrist, and we clearly see it with the largest increase in the foot. So in other words, at baseline, if they've had disease duration for up to 40 months, they're much more likely to have erosions than if they've had it for 1 to 2 months. When we look at joint space narrowing, we see a similar picture for the feet and for the wrist and for the MCP joints, but interestingly enough, for the PIP joints, the lines are flat, meaning, as I said to you before, when they had joint space narrowing, they had it at baseline with the 1 to 2 months of disease duration up to as much as 40 months of disease duration, and it didn't really change very much. So now the next thing to make it a little bit clearer is that we now understand which joints appear to have damage early. And for erosions, it's the MCP1, it's the navicular joint, it's the IP1 of the foot, MCP4, and MCP3 of the hands. For joint space narrowing, it's PIP 3, 4, and 5, the navicular joint with the wrist, and finally MTP1 of the foot. And it's interesting that when you would see 50% of patients to be estimated to have either joint erosions or joint space narrowing, it was generally earlier for erosions. So we've thought that before, but I think it's of interest. Now, if you look at progression over the full 2 years of treatment, what we can see is that the joints that were also most likely to have damage at baseline tended to be the ones that showed the most progression. And when we looked across the different joints, we could also see that there was more progression in the methotrexate group than in the adalimumab plus methotrexate group, as we might have expected. So looking first at joint erosions and seeing what happens over 2 years, what we see is that the joints that show the most change are the foot, IP1, MCP1 in the hands, and then we see a lot in the other MTPs of the foot, and we see a fair amount in MCP3. So these are erosions and probably, again, reflect how people use their hands and how they walk. For joint space narrowing over this 2-year period of time, there's actually fairly little progression in the wrist CMC 4 and 5, but what we see actually for the navicular is that there's a lot of progression in joint space narrowing. And then, as I mentioned to you before, the PIPs seem pretty stable. They show some progression, but mostly they've shown that progression already. Then we go back to the odds ratio progression of either joint erosions or joint space narrowing from baseline to week 52. And the reason we picked 1 year was because, again, there was much more progression in the first year, much less so in the second year, so we could see the differences better in the 1 year change scores. And for the 1 year change scores, as we've already talked about, it's the same type of pattern. So the odds ratio for more involvement with erosions is again going to be higher in the hands, MCPs, PIPs, and to some extent the foot. And the progression of joint space narrowing is actually a little bit less in many of the joints, but we see it in MCP5, and we see it in the wrist and the navicular, we see it in the radial wrist, and we see it in the foot joints. So finally, when we look at the pattern, now we're not looking at cross-sectionally, but we're actually looking at the probability of joint progression over 1 year or in both erosions and joint space narrowing. We see a pattern which looks very much like there's less progression over time. And this is particularly true with the green line, which is the combination therapy, and less so for methotrexate. Although over time one sees that the progression in most of these joints goes down. However, there are some joints where there's persistent involvement, persistent progression, as it were. It doesn't increase, but it doesn't actually go down. And the persistent progression is in the wrist MC1 and the foot MTP1 and all the other MTP joints of the foot, interestingly enough. And then in some of these joints, one sees that the progression over time does actually go down. Again, MCP5 still shows progression over time. MTP5 of the foot still does. And the wrist and radial also show that kind of straight line. For erosions, we see that there's a pattern. For joint space narrowing, we see slightly different pattern. So we don't see quite as much involvement early, and we see in some of these joints that actually it increases over time. But in large part, there's a flat sort of progression rate in joint space narrowing. And that again may reflect how the joints are used. Some of the joints have very little progression over time, like the PIP5. And by and large, some of them are essentially flat. So PIP2, the wrist CMC3, the foot MTP 1, 2, 3, 4 look fairly flat. So they're getting more erosions. The probability is still there, but in fact, the joint space narrowing is fairly flat. So the conclusions after all of this is that we now understand better which individual joints have involvement at baseline and what the effect of disease duration in a very early disease population is, and that's of interest. I think it helps us to understand that we really do see a lot of progression in the joints that are stressed by use. So the joints that we think about in our hands, our fingers and pinching and typing and so on. And of course, the feet are going to show a lot of damage because we're walking on them. It's interesting that joint erosions was a little bit more pronounced early disease, but we're looking at an early disease population, and it's very fascinating to see that the PIP joints have joint space narrowing early, and it remains, although it may not progress that much. So I think we understand now that we're probably looking at two different anatomical processes that are driven in part by the kinds of stresses that we put on our joints. Also, these findings are similar to what we did as a survey in OMERACT for the SHARP Symposium, where we looked at 3 different data sets with x-rays and ascertained which joints were most involved at baseline and which most showed progression. However, we did not have a very early disease population in that survey, and this survey now actually supplements and confirms the findings. So it says that we really can't do a more abbreviated x-ray survey when we're looking for inhibition of structural damage. But it also says that when we're looking at a more abbreviated survey, as we do an MRI with the wrist and the MCPs and PIPs, we're still going to see the picture that has been shown to us by radiographs for the past 15 years. Well, interestingly, some have asked why adalimumab monotherapy wasn't included in this analysis. As you may remember, it was statistically by radiographs better than methotrexate, but it was actually the combination of the two that was of more interest to us than the standard methotrexate in a naive population. I think also it was the choice of the sponsor, and the sponsor did all of these analyses, which were very time-consuming and would not be something that most statisticians and independent consultants would have the ability to do. So this has taken a long period of time to get all the data together, and it was basically for an academic interest of what joints would show change, and we figured that the best comparison would be our gold standard methotrexate monotherapy versus the combination. So one of the questions I think was how typical was this pattern of progression across individuals? Well, there's a lot of heterogeneity. So you may remember that at baseline, no more than 60% of patients actually had erosions in any given joint, and no more than about 40 to 45, 50% had joint-space narrowing in any given joint. And the most significant predictor of progression at baseline is damage at baseline. So those patients who already have erosions or joint-space narrowing in their joints, those are the joints that are going to progress. Many of the patients who didn't have damage in certain joints were unlikely to develop damage in those joints, but some did. So it's still very heterogeneous. However, the homogeneity of it is that certain joints are more likely to develop damage and then progress. And this was even true in patients who did not have involvement at baseline. So I believe that someone was asking me about whether we would consider using adalimumab monotherapy in a higher dose. Well, yes, it is approved to be given as 20 milligrams once a week, but it was not studied per se in that dose except in the phase 3 studies, and this was a phase 4A study. It was started before approval, but it was finished after approval of adalimumab. And I think the question really is you wanted to use the standard dose of adalimumab, and most people don't think about using an increased dose of adalimumab except in people who have had response and then lost response. And I'd say to you that most of the time in these studies, when we've looked at increasing doses of TNF inhibitors, with the exception of infliximab, increasing the dose has actually not accrued more response. So I'm not sure that it would be a very efficient way of understanding the effect of adalimumab monotherapy on X-ray progression. So this was a discussion about the adverse events observed in this trial, and particularly with combination therapy. This trial was published quite a few years ago. It was finished in 2003. So to be fair, all of that data is out there, and there have been extension studies as well. And yes, there were more adverse events in the TNF arms. Remember that after year 2, people were then decreased to monotherapy or switched around. So the data is really good and understandable in a blinded fashion for the 2 years that the trial was conducted. And the data in the extension study is confounded by switching therapies, etc. I don't think at the present time this is actually applicable to what we were discussing. We were trying to use this study population to understand better what radiographs can tell us about how RA affects joint damage. And I think what we did show you is that actually there's a very different pattern for damage based on erosions versus joint space narrowing, that they probably are two different physiologic processes, and they're influenced also by how the joints are in fact stressed. So it's different if you're walking on your feet or you're using your hands for the kinds of fine detail motor functions that we normally do on a daily basis.